National Health Summit here in Kiev, Ukraine. I'm Dr. Dr. Douglas Davis. I'm Doug Davis. I'm a physician from the United States. I'm a part of one of the co-organizers of this health summit, the medical NGO Med Global. They're a U.S. NGO based out of Chicago, Illinois in the United States. And we've partnered with August Mission, a group based out of Utah in the United States, to organize our second annual healthcare summit. And as most of you still here in the audience today, experienced yesterday, we covered a wide range of topics, sort of broken down along three major tracks, looking at the various consequences of the war in Ukraine, particularly from a trauma orthopedic standpoint. We heard from several frontline surgeons who have incredible experience with the full breadth of consequences that they see there, everything from tourniquet syndrome, wound amputations, massive complex polytraumas, and the consequences of that they see that have very significant downstream effects both on wound infections and the need for prosthetics and rehabilitation. So we covered that as sort of part of track one. We had a section to discuss more specifically the very large-scale needs for prosthetics and rehabilitation. And then we also had some topics with our track three, which is the major mental health issues. We heard numbers from some of our colleagues which said that from a public health standpoint, Ukraine faces a epidemic proportion of mental health issues. As many as 15 million people in the country meeting what we would call diagnostic criteria for everything from anxiety to depression to full-scale PTSD, and what the very large-scale implications are that for public health and for civil society in Ukraine. So yesterday we had a more traditional format of lectures, and we had a fantastic panel discussion with some of our frontline surgeons. Today in this track we're coming at it with a slightly different approach, where we're going to basically have an interactive discussion about some of the topics we addressed yesterday. And on this track, we're going to focus specifically on the trauma and orthopedics issues. And for the first part of the discussion, we'll be going over tourniquet syndrome, which is actually a major healthcare issue on the front lines, which is unique for the war in Ukraine. And just to go back over some of the overview of that, tourniquet syndrome is essentially the consequences that when there are massive polytraumas with everything from mangled limbs to traumatic amputations, one of the largest causes of death near the front lines is blood loss. So tourniquets, as we were told, save lives, but they need to be applied in the appropriate indication and under the appropriate protocols, or very significant consequences such as tourniquet syndrome, which is where essentially the blood supply to the limb is limited for such an extended period of time that the limb essentially dies, and that leads to very significant, broader consequences than just the damage to the limb per se. Leads to kidney failure, leads to multi-organ failure. And so we're going to have a panel discussion here today. We have some of our colleagues, Dr. Michael Samotowka, who is a surgical lead for our medical NGO Med Global. We have his colleague, Colonel Dr. Gregory Prohorenko, and I'm sorry if I'm butchering your name. So we're going to go over some of the topics we discussed yesterday and dig in a little bit more deeply. And we also have coming to the stage our good friend and very esteemed colleague, Dr. Hudson Berrey. He has been one of our surgical volunteers with Med Global, Razom, and other NGOs from the United States that are doing healthcare work in Ukraine. Dr. Hudson has a exhaustive background in this work, 25 years in the U.S. Army, serving as a colonel, was head of orthopedics and trauma at Walter Reed Military Hospital, went on to a very distinguished academic career, and now in his spare times he goes and tries to help save lives in Ukraine, and has been a tremendous asset in all of the work we do. So just to get started, I wanted to bring up the PowerPoint presentation from one of our colleagues, Dr. Dmytro Beshley, the brother doctors Andrei and Roman Sobko, and they talked in great detail about tourniquet syndrome yesterday and various aspects of that. And I just wanted to go back and cover at the outset just some of the statistics. So when they said what they are seeing at their frontline stabilization points is that when traumas are coming in, as many as 41% of the patients they're seeing are arriving with tourniquet syndrome. And the downstream effect of that from a number standpoint is that if they arrive and have clinical diagnosis of tourniquet syndrome, as many as 85% of those cases will lose the limb, and the really shocking number was that 40. That's because of the more systemic consequences of tourniquet syndrome, where the limb has died from prolonged deprivation of blood supply, leads to downstream effects in kidney damage. Dr. Roman Sobko gave us some very detailed exposition on what he has done to try to mitigate that using dialysis and other techniques. They talked extensively about the rapid blood tests that they're using to basically assess the triad of apologize for that, the triad of death that ensues. And so this is a major issue on the front lines, and we have some of our colleagues here on this first discussion group that I'd like to get their experience and their input and their insights on some of these numbers and what can be done to make an impact on this issue. So I'd like to start with Dr. Michael Samotowka. Dr. Michael Samotowka has been making surgical mission work to Ukraine since the beginning of the war. I mean, dozens of trips here. He has actually been to some of the frontline mobile hospitals with Drs. Dmytro Beshley, Drs. Roman and Andrei Sobko. So he's had a lot of very firsthand experience, and I'd just like to start with your input on this, Mike.
You hear me? Yeah. So let me take one step back and just go give a little bit of a historical perspective and what my experience has been in the United States and in Charlotte, North Carolina, where I currently practice. So in America, historically, the popularity of tourniquets has come and gone. There was a period of time where we used tourniquets quite frequently. They then fell out of favor, and then they came back. As was very well presented yesterday, tourniquets can save lives, but we have to be very careful about what the indications are for using the tourniquet, when to apply the tourniquet, and the proper positioning. So even within the last month in Charlotte, North Carolina, where I practice in the United States, it's a city of about 1.5 million people. We're an inner city trauma center, so we see a high volume, about 3,000 trauma patients a year. At some point in the last year, the police department in Charlotte was authorized to apply tourniquets on patients. And I can recall one case where an elderly lady fell in a nursing home, scratched her paper-thin skin on her leg, and basically suffered a very minor flesh wound, but had a tourniquet applied well above the knee, almost in the groin area, by the first responders, which were the police. Unfortunately, there was a delay in getting an ambulance to the nursing home to bring her to the hospital, so she spent about an hour with a tourniquet on her leg, and when she arrived at our trauma center, her leg was as purple could be, underperfused, you know, developing acidosis, high potassium, all the ramifications of dead muscle. The first thing we did when we took her dressing down and looked at her leg was I simply took the tourniquet off, and there was no active bleeding. So what happens in Ukraine also happens in the United States. We really have to stop and think who needs a tourniquet versus who can be treated with simple direct pressure. And the other issue is where to apply the tourniquets. So taking a step forward now, NATO has always taught us to put the tourniquets high and tight. And when you look at the American conflicts in Afghanistan and Iraq, the time from injury of a soldier to the time that they were on the operating room table in front of a trauma surgeon, ready to be properly taken care of, was an hour or less. And so it's a very short transit time. So in that situation, if you inappropriately or incorrectly placed a tourniquet, there's essentially no loss. It did develop some acidosis, some hypoperfusion, some elevated potassium, muscle necrosis, but it was a salvageable situation. The situation that we deal with in Ukraine is very different. There's a prolonged period of downtime in the field. We don't have air superiority over the Russians. And so it can take a very long period of time to get the patient off the battlefield into an ambulance, and then it could take even potentially a longer time getting that patient to a frontline hospital. In that situation, what we're seeing with that prolonged period of time of underperfusion is worsening acidosis, worsening muscle necrosis, high potassium levels, and things which, and also hypothermia. So you see that whole triad of death, acidosis, coagulopathy, hypothermia, which is exactly what Drs. Sobko and Beshley were speaking about yesterday. In this situation, I think we need to take a step back, look at the NATO guidelines, and see if, as we apply these guidelines to the situation in Ukraine, should we rethink a few of these basic concepts? Should we really be placing the tourniquet high and tight, or should we be applying the tourniquet a few centimeters above the obvious injury? Should we be leaving the tourniquet in place for a prolonged period of time, or after 1 hour of application in a controlled setting under supervision of a medic or a physician, should the tourniquet be released, loosened, but left in position? If you loosen the tourniquet and you allow the limb to reperfuse, you are taking the risk of releasing the acidosis and the high potassium and the muscle necrosis into the system, which potentially could harm the patient. But if the patient is no longer actively bleeding with the tourniquet loose, I would propose that leaving the tourniquet in place, but leaving it loose and not tight, would get us a better outcome. As Dr. Davis had mentioned, I did have the privilege of going to some of the frontline hospitals and seeing firsthand some of the problems. And we've also been dealing with this in some of our training sessions and discussing this topic. I think this is a very, very important topic that clearly needs to be addressed. You know, primum non nocere, above all else, cause no harm. That's our principle. And if we stay true to our principle as physicians, maybe this is the time for us to rethink how we are treating traumatized patients in Ukraine. And can we do a better job and provide better care for these patients? Because that's ultimately our goal, is to provide optimal care for those who have volunteered to go to the front to serve their country, to serve all of us, because we're in this all together. And we owe it to them to do the best that we can for them. You saw the numbers on the previous slide. Actually, Doug, if you could bring that up, I think 41% was what Dr. Sobko had claimed was death related to tourniquets. Go back one
I think it
more.
was 41% who show up with tourniquet syndrome.
Yes.
And the exact
Correct.
numbers for, one second. Yeah, there we go.
Yeah.
If they have tourniquet syndrome, 85% will lose the limb.
Yes.
And up to 41% will lose their life because of the triad of death.
So that's a huge mortality. And I'll defer to my colleague on this panel, Dr. Hudson Berrey, who's an expert on amputations. But just very briefly, as a general trauma surgeon, there's a huge difference in terms of return to quality of life and functionality when you're dealing with a below-knee amputation versus an above-knee amputation versus a high above-knee amputation, where you're getting almost to the point where you need to do a disarticulation of the extremity at the hip. And we're looking at significant mortality. So the higher up we go up the limb, the more difficult it is for the rehabilitation of the patient. And we're dealing with issues of quality of life, recovery, and the ramifications of all that.
And Mike, I think that's an interesting segue.
Sure.
Dr. Hudson Berrey, and that's exactly what I wanted, is Dr. Hudson Berrey has extensive experience going back to multiple wars for the United States and seeing the evolution of the application of tourniquets in combat and of the TCC guidelines, the Tactical Combat Casualty Care Guidelines. And I'd like to get Dr. Berrey's perspective on that from a historical standpoint, and to the points that Dr. Beschley brought up about tourniquets can save lives. Their application needs to be individualized, but it also needs to be standardized. And so just your perspectives on that, and then to Mike's points about, as head of ortho at Walter Reed, and seeing what the consequences after the fact, what that means for the soldiers, and your insights from Ukraine on that as well. Dr. Berrey? Mike, you might want to hand him the microphone.
Push it down. Okay. Just once. Okay. I can be trained. I can learn. Well, you know, I think the whole crux of this issue is, are we using tourniquets appropriately? So how many of the people who have tourniquets actually should have a tourniquet placed on them? And that's the key question on this, because we have, I mean, the saying in surgery is all bleeding stops. You know, you either stop it by physical means, or the patient runs out of blood. All right, but all bleeding is going to stop. The appropriate use of a tourniquet is when there's uncontrollable bleeding. that you cannot stop with standard procedures, which would be pressure dressing. You know, in our tactical packs that soldiers have, they have ABD pads. You know, what is an ABD pad? And what does ABD stand for? Well, in common parlance now, ABD stands for abdomen. But in the beginning of this, it was an Army battle dressing. That's what an ABD was. So I think the question we're dealing with is because we have overtrained people that it's kind of a memory thing that if you see blood, you've got to put a tourniquet on, and that's absolutely not the case. So if you want to put a tourniquet on, go ahead, but try your best to stop the bleeding without the tourniquet there. And then if you can't stop the bleeding with that, then use the tourniquet, okay? Because, as I said, all bleeding stops, and you want it to stop with pressure, either manual pressure on the wound itself or the pressure of a tourniquet. You don't want the bleeding stopped because there's no more blood left in the patient, okay? So high and tight was good, but is when you have immediate means of evacuation, right? If you have a prolonged evacuation chain, and that's the norm, I mean, our norm when we developed these guidelines was we had rapid evacuation. That is not the new norm. The new norm is the delayed evacuation. And as we heard yesterday, this can be anywhere from 6 to 30 hours. And so we saw that timeline of, you know, we use tourniquets in orthopedic surgery, okay? It makes a bloodless field, you know, and orthopedic surgeons like things simple, okay? Blood gets in the way. Our general surgery colleagues are jealous because they don't get to put the tourniquet on the abdomen, you know, or the belly or the heart. So, but we have a rule, we have a timer on our tourniquets in the operating room. We have a timer that goes off at an hour, and then every 15 minutes it goes off, and a 2-hour time limit. You fudge that a little bit sometimes if you have to, but a 2-hour time limit. After that, you're getting into trouble. And then if you're getting into trouble with that, you're going to end up in a courtroom or writing out a big check to somebody with that. So that's the key question of how do we intervene, you know, how do we change the mindset of the soldier or the medic so that they put on the tourniquet appropriately. What's appropriately? It's put it on loosely and then stop the bleeding. If the bleeding can't be stopped, the tourniquet should be put at the lowest level right above the injury. Because, as was mentioned, the more limb you take off, the harder it is, the more energy it's going to take that person to walk in the future. Again, with lower extremity amputations, longer is always better. You just need to be able to cover the end of the limb with good serviceable padded tissue. All right? The books are wrong on that. The books are wrong, and they'll say, 12, 15 centimeters below the tibial tubercle. All right? That's absolute nonsense. You talk to modern prosthetists and says, the longer you make the limb, the better that patient is going to do. I said, well, I mean, can you do it all the way down to the ankles? Yes, modern prosthetics are such that you can keep the entire tibia. You just have to be able to modify that so that the patient can walk, so that it can fit the prosthesis. But you have to have a prosthetist who understands that length is everything to the patient. The longer the limb, the less energy it takes for that patient to walk, and the more normal their lives will be. All right? And so I was an advisor in El Salvador in the 80s during their civil war, and they had problems with homemade booby traps that the soldiers would step on and blow off their toes. And each one of those soldiers ended up with a below-knee amputation, done exactly like the book said, 12 to 15 centimeters below the tibial tubercle, so they were short. So one of the projects I took on there was to teach them that you could just, you may be able to end up with a mid-tarsal amputation or what's called a Symes amputation, where you're taking the heel pad and running it underneath the length of the tibia. And with that, you can stump around on without a prosthesis if you have to. And if you don't have prosthesis, or the availability is limited because of distance, time, professional, prosthetist, whatnot, then at least they can get around. And I had a number of patients in El Salvador who made their own limb. They fashioned it out of the PVC, and they kind of created a socket, a piece of PVC, and they carved a foot. Used a lot of duct tape. But you can do it, okay? The trick is that you want to save the length. So the question for the audience, and I would like to get this feedback, and if you don't volunteer, I'll call on you, okay, is how do we teach our young soldiers who are very scared, bullets are flying, their buddy's been shot, he's bleeding, he's screaming, or the medics who are out there, they got drones flying around targeting them. How do we get them to understand what this situation is and how to apply tourniquets appropriately?
Maybe we can actually ask Dr. Prohorenko what his thoughts are to that question. About not to put you on the spot, sir, but you probably have a lot of experience, particularly seeing what comes from the front lines to the rear and the consequences. So, your thoughts, sir?
That is true. That is true, what you're saying, because the amputations and the consequences of amputations are a major problem that we have encountered en masse. As of now, in Ukraine, there are a lot of people who require prosthetics as a result of injury received in combat. And not always this is simple, because this requires multidisciplinary trained teams and specialized prosthetic experts, manufacturing facilities. And the most important, that this is a social problem, which is a burning issue for the public, because these people need to adapt to normal life. They need to adapt to living again in society and the other way around. for them, for people who defended the motherland, it's a major problem. The tourniquet syndrome leading to the aforementioned consequences, yes, indeed, that is true. All the trainings for the soldiers are based on NATO countries' experience, and the idea is to apply the tourniquet as soon as possible, high and tight, to stop the bleeding, and then fast evacuation. And after that, it's time for combat medics or medics and doctors from various medical units. But as experience suggests, presently it's virtually impossible because it takes a lot of time to arrange evacuation, and 6 hours wait time for evacuation is more of a rule rather than an exception. And the soldiers who had their training at shooting ranges, they normally learn to apply the tourniquet the way I just mentioned, high and tight and as soon as possible. And it's hard for them in combat to assess how severe the injury is. They see blood, they see the wound, they have normally several tourniquets on their person, and they would apply tourniquets to pretty much every limb they can, and they would apply it high and tight. It is very hard for them to identify whether there are indications for that. And first and foremost, what they are thinking in combat about saving their life, and then about saving limbs. However, the doctors that those patients are taken to later, they would identify whether the tourniquet was applied in line with the indications or not. And as of now, there are indications for the conversion of tourniquets, and we are trying to implement that for the troops to make sure that as many people as possible are aware of how the bleeding can be stopped. So to convert from tourniquet to pressure dressing or hemostatic means. And what's also relevant is teaching people to apply tourniquets not high and tight, but closer to the wound, and to control how efficient the tourniquet is. As soon as the bleeding stops, then the tourniquet needs to be loosened. It cannot be tightened further. Can it be done quickly? No, unfortunately. This would require training of the military personnel, the rank-and-file soldiers, not only the medics. And combat medics, in turn, they need to be trained. They need to know how to relay that knowledge to their combat buddies. And those who provide help to their bodies and provide self-help, they need to know about that. And the factor here is that the time it takes for evacuation to arrive doesn't always depend on them. And all of those factors define the consequences for a specific wounded person. Because there might be infections, amputation of the stumps, etc. All of that requires major effort and trained teams. And that's all the way to before starting to talk about prosthetics, so it's a lengthy process. There's a lot of combat-related stress. There are a lot of people with mental health trauma. So rehabilitation process needs to happen for these people, not just physical, medical, but also rehabilitation for their mental trauma. It all has to start with the training of soldiers and medics. at the stabilization facilities closer to the front line, evacuation facilities. They have to be oriented towards preserving of limbs. There have to be methods to establish viability of the injured limb. There have to be very clear indications for either amputating or keeping the limb, because we all understand that this is not a simple surgery. It's not just simply cutting off a limb. No, the changes that happen in the body, they can last a very long time and require a lot of effort to save life, not just the limb. So only through joint effort with medics, with the medical services, with the military unit commanders, through respective trainings, we might be able to overturn this devastating effect that tourniquets can cause. However, I should say that, of course, tourniquets can be used, but it requires very careful considerations how to apply the tourniquets correctly. And tourniquets, of course, are one of the ways to save life and to save limbs. And unfortunately, modern weapons evolve much faster than we manage to adjust to different types of trauma, and it takes much longer time for us to decide what we have to counter that.
Thank you, Dr. Prohorenko. I think Dr. Hudson Berrey has some follow-up. And Hudson, one thing, you've mentioned this, and Dr. Prohorenko kind of touched on this, the guidelines that NATO has set, which is been effective for our soldiers because they have air superiority and rapid evacuation times, are part of the problem, because those have been adopted, and they've been adopted now with conditions that are very, very different. And Dr. Prohorenko talks about how there's some major hurdles and obstacles to overcoming that. And so maybe you can also speak to what we can do. We're here to work to help our Ukrainian partners. What are your thoughts?
This, I think, is ultimately an education issue, but in the military, it is also a command issue. In our units, our combat units, when we have patients lost to disease and non-battle injuries, and as I mentioned in my remarks yesterday, historically, disease and non-battle injuries, mostly disease, has been the greatest effector on loss of combat power throughout history. We had cholera, we had GI diseases, pneumonias, and again, these are in the eras before antibiotics. One example of this is that, you have to have, you change socks. You tell soldiers to change socks. Well, changing socks to keep from having blisters or letting your feet dry out is a hassle, all right? And anything that soldiers do that is going to be difficult or, a hassle for them, they're going to want to not to do. So it's a command issue, which means that there's a chain of responsibility for the commander of a unit, down to the sergeants of the units, to the squad leaders of the units, to make sure that their soldiers are changing their socks to protect their feet, or they take their anti-malarial drugs if they're in a malaria-prone zone, And this, again, is this issue of tourniquets, to my way of thinking, is a command issue. And so I think that it has to be emphasized to unit commanders, combat unit commanders, that this is the way that it has to be, that proper use of tourniquets, and then that filters down to the squad leaders, and that's down to the individual soldier level, and that's where the change stops. But again, is there a feedback? So you have a soldier in your unit who is shot, injured, is evacuated, that soldier is lost to you. Is there any feedback to the unit as to what the outcome of that injury to the soldier is? So does the unit find out that Private Jones, was shot through the leg, was evacuated? It wasn't a bad wound, but his tourniquet was left on too long, and his leg was amputated way above the knee. And does that get back? So if that feedback loop was directed down to the soldier level, back to his unit, I think there might be an impetus for change then. Because if they know their buddy lost a leg that he didn't have to lose, then the other soldiers in that unit says, maybe I need to be changing the way I apply a tourniquet. So
we wanted to keep this interactive and give the opportunity for anybody who would like to weigh in here, who has experience here or has some thoughts or insights in here. So bring up the microphone. If you could just introduce yourselves, tell the audience where you're coming from, what your background is a little bit, and
hello, everybody. My name is Andy Kuzic. I'm a former UK Royal Naval officer many years ago. I'm not a medic. I work for a medical charity in Ukraine called Lifting Ukrainian Lives. I work closely with the British Embassy, and I'm focused on outcomes. What can we do today that's going to make a difference? We have here some very experienced surgeons, that's very clear. But I think as Hudson identified, the real core of the issue is education for the soldiers. And I have two questions. Number one, Operation Interflex, which is run by the British government, has trained 45,000 Ukrainian soldiers in basic battle tactics, but also combat medicine. And my question is, do those trainers in the UK know what you've just been talking about Tourniquet syndrome? That's question number one. And should we check and maybe help them change their training techniques? Are they using old NATO high and tight? That's one question. Number two, soldiers, I dealt with sailors, and sailors are very simple people, like soldiers. They need simple instructions, nothing complicated. If we changed IFACs and put on the IFAC, on the tourniquet packet instruction, warning, if you keep this on more than 6 hours, you will lose your limb. Would that help the soldier make the right decision?
you read my mind. We have discussed this, I've been involved with Ukraine for the last year and a half, and we have discussed this, and my thoughts on it is that we should have just exactly that on each tourniquet as an indelible card with cartoons on it with that, and also include in that a little kitchen timer, a little 1 hour timer that gets turned on when the tourniquet goes on. So when the timer goes ding, 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 ding at the end of the hour, you reassess. Those were my thoughts on it. Now, as far as what the British training is, I don't know if they get any feedback. It would be if you have contacts that can get to the people who are doing the training, I think it'd be very interesting to find out exactly what their training is. And again, if there's Ukrainian soldiers in other countries that are undergoing training for the same reason, what is theirs? And is there, and I guess Dr. Colonel Prohorenko, how does the Ukrainian military understand what the training is that they're going through in outside the country? Question here.
Yeah, Ian Nez, but also ex-British military. I was a medic.
Yeah.
Now working for David Knott Foundation doing training.
Yeah.
My question follows on nicely from what Andy's just asked. How do you ensure a unified training system when there are so many different trainers, both within Ukraine and outside Ukraine? And is this a role for the Ministry of Health or the Ministry of Medical Military Medicine in Ukraine to produce a standardized training requirement for everybody who trains frontline soldiers?
I will defer to you.
З приводу
With regards to the training of our soldiers in the interflex operation, of course there is feedback, and our British colleagues and US colleagues, by the way, and our medics, we all are keeping cooperation, and everyone understands the problem that is there. So the methodology of training of the soldiers is changing. Talking about the training of combat medics, not only soldiers, that now gets much more time than before, and the training bases are created not only in the UK, also there are in Ukraine, and the program expands, and people who are involved in training programs, they are aware of the issue. And now the practical guidelines and tourniquet curvature are already there. They are now mandatory for the service members, and in the training, like more time is dedicated to care when both the medics and the soldiers are trained. So the units are being trained, but we understand, of course, that people who previously were not involved in army, that's one thing, and medicine, that's the other, they need a lot of attention and supervision in training. And as was duly said, as sailors who need to have simple instructions to do it, well, this is required. I agree. So now we focus a lot to make all the training practical. Less theory, more practical awareness of what is there in the IFAC or in combat medic kit, and the awareness of how to use that. And everyone must understand that a tourniquet can also harm, not only help. And the prevention of harm, it's part of the training. Whether it's effective, we'll be able to tell when we get the information.
I think the main point that we're trying to understand is how can we implement change, you know? And when you do that, you need everybody's input. I mean, there's ideas come from everywhere. You know, what are the ideas that people have on how can we affect change? Because the cost to the country for caring of the amputees and those with other physical injuries are going to last much longer, and they're going to continue to mount after the bullets quit flying. These are going to be long-term costs to the country. So it's an important aspect. You know, yes, it's individualized. They're individual tragedies that happen all the time. And what we know is that the frequency is decreasing, so the word is getting through. As we heard yesterday, that the incidence of tourniquet syndrome is decreasing. It fell by 14%. You know, I don't know what that truly means. And drills down, does it mean that we have 14 fewer amputations with that, or there are the consequences of that? But you know, so the word is getting through. You know, our efforts in this are making a difference, but is it enough of a difference, and is it enough of a difference fast enough to help? And I would like anybody else to chime in on this, to tell us their thoughts, and anybody who has experience taking care of these soldiers or is involved with their evacuation, and how do you deal with them once they're in the evacuation chain?
And actually, we have an online audience as well, and I
excellent.
think do we have a raised hand online? Okay. Someone's communicating with me. I think they're going to try to raise their hand, and if we could tee them up next. But does anybody else in the audience have comments there? Because if not, you bring up a very important point, Hudson, that was talked about yesterday, both by Dr. Homanyuk and by Dr. Beshley, about this cost issue, and that there is sort of actually maybe a conflict between the short-term cost versus the long-term cost. And for the surgeons, both in terms of time, but energy, and saving costs in the immediate sense, sometimes doing the amputations and just sticking with the old ways of tourniquet application costs less, because there's training, there's time and resources when they're getting huge volumes, but the downstream costs are enormous. If you can salvage limbs and or do more tissue-sparing amputations, your experience is that's going to save costs for both the prosthetics and the rehabilitation. And so, and my question is, or my thought is, what's the degree to that conflict between short-term costs and long-term costs may impact the decision-making on adopting some of these changes? And perhaps, Dr. Prohorenko, do you have any thoughts there?
Being involved in caring for the wounded patients and amputees, we do not only look into the short term, because we understand that these patients and we with them are already seeing a huge issue. Number one, there's tourniquet. Number two, there's evacuation. Then three, there's the primary surgery. Then there's another evacuation. Several stages of care. The patient is being transferred from one medical unit to the other, and as the result, they get to a hospital which would finally create the stump, and it would take months. And the effort it requires is very significant, both material cost and physical. So it starts with expendables and down to the efforts of the multidisciplinary team, because it involves not only surgeons, there are anesthetists, psychologists, rehabilitologists. It's a huge team. And then after that when the patient is ready for the prosthetics, we try to do it as soon as possible. Then they transfer to the rehabilitologist and prosthetic specialist who would do first the primary provisional prosthetics, then the permanent prosthetics, and of course the length of the limb is in direct correlation to the cost of the prosthetics. If we talk about the ankle level amputation, that's one thing. If we talk about the amputation where the knee is preserved, that's also a thing. If the knee is lost, if there's high amputation, the femur, then it's a different thing. And if we talk about the osteo-integrated prosthetics, that's also a different situation. We understand it has its own indications and it requires so much effort from the doctors and the patient. And we must be aware that the prosthetic which the patient is going to use costs more than a car, and it requires also maintenance and the replacement of parts and servicing and so on. That's expensive. All that is expensive, and time-wise, it's long. And of course, once the conflict is over, then the situation would still persist. So we are preparing to the situation when wounded people who were defending our country, they would still require our help for a really long time.
Let me just add to that in terms of the cost, which Dr. Prohorenko just talked about. You stop and think about the cobble streets of Lviv or the streets of Kiev or any of the other cities in Ukraine, and now you have a significant number of people that are going to need access, wheelchair access or access to restaurants, to homes, to buildings, to function in their activities of daily living. This society is going to have to make huge changes in the infrastructure to allow these people to continue to live with a good quality of life. One thing that I'd just like to add to the previous discussion was we have a lot of NGOs working in parallel, doing some of the training, and we have training coming from Britain and France and Germany and the United States, etc. I would look to the Ministry of Health or the Ministry of Defense to better coordinate and make sure that everybody's on the same page and that we're giving the same level or same quality of training, so that what's given in one course is identical to what's given in another course, and so that everybody is writing from the same book and on the same page in terms of what we're teaching and what we're doing.
And I believe we have someone from online, Dr. Roxlana. Roxlana, when you come online, could you introduce yourself and just give a little background, please?
Hi, sure, thank you. I can speak in Ukrainian or English, or I can just do both so that it's easier for the translator. My name is Roxlana Hurpove. I'm a general critical care surgeon in the US, and I've been teaching TCCC officially, being trained by the German military since 2014. And we started teaching this at the Lviv Medical Military Hospital in 2014. Я можу сказати по-українськи.
I can say that in Ukrainian. I was born in the US, and starting in 2014, I had the opportunity to study TCCC upon the invitation of the German military, and Since that
instruments
time,
українськими військовими
I've
почали
been
впроваджувати
working with
TCC
Ukrainian
в
military
Україну.
training to implement
І
TCCC in
одна з
Ukraine.
найбільших речей, що це вчило, що TCC все вчило, але не було
So
явно окрема
there
навичка,
was no
не
special
було високого
skill
нагляду здобуття, але вони
to
це проговорювали
applying
на навичках, де є,
to
власне, це, щоб
triple C.
якнайшвидше
Audio
здійснити,
quality is not so good
замінити
interpreter.
чут, і
It's not enough for the
що це
interpreter.
можна або замінити на поховання,
So in terms of tourniquet replacement or using the pressure wound, it's a pressure dressing. It's never been a skill.
Speak to Dr. Butler about this. He emphasizes this has always taught to keep the tourniquet on as short a time as possible, and in to packing or a lower tourniquet has always been taught in TCCC, although it wasn't a separate skill station, because as others have said, there wasn't a need necessarily for that, but we went through it in speaking. And one of the things I think that someone got lost in the massive need for training was that piece, because it wasn't a separate skill station. So I wanted to explain that because I very much support that we need to have better education, but better education really probably of what we already have and what is the native standard, and Ukraine wants to be in line with native standards. So that's one thing, that tourniquet conversion is in place. And now we are teaching tourniquet conversion, we have been, to everyone. Everyone who goes through TCCC for all service members, so that's the most basic level of TCCC, it gets taught tourniquet conversion as well, including last week we taught journalists how to do this. The second thing that I think warrants attention is how tourniquets are placed, meaning like where tourniquets are placed. TCCC has always had 3 phases of care, depending on your situation. So the easy way of saying that to those who may not be familiar with the technology is the red, yellow, and green zones. The red zone being under fire when you're actually being shot at or have a direct threat. The yellow being an indirect threat. So if you're behind a rock, behind a door, any kind of cover, then you're considered to be in the yellow zone. And then there's evacuation, much safer zone. And so under fire, so the red zone, you put a tourniquet high and tight, right? But when you move to any kind of cover, then a tourniquet would not be placed high and tight unless you can't see where the bleeding's coming from. But that's an opportunity already there to first put direct pressure. We always suggest first putting direct pressure, and then assess the wound either for packing, if you can pack, or if you can't, then to put the tourniquet only about a palm width above the wound. And again, I think that because there's been just such a move towards, expansive need for training, you hear many people just saying, I do march, and they forget about the different steps and the different phases of care. And so when you are in the yellow zone already, you reassess the tourniquet that was put high and tight. If it's still bleeding, you can tighten it. You go on and find all other areas of life-threatening bleeding. And we really emphasize that it has to be life-threatening, not just any kind of bleeding. And your first attempts are with direct pressure, packing if you can, tourniquet if you need to. And after you've done your whole march sequence, right, which is essentially the primary survey of ATLS, then you go back and do conversion. That's in the yellow zone. When you're already in the green zone, then again, everything is much more deliberate and intense. So we understand that in Ukraine, it's very difficult to get to the green zone, right, to get to evacuation. But there are situations of the yellow zone where you have indirect threat. The situation may change in time. And perhaps one thing that needs to be emphasized more is that when you're in, and we're emphasizing it even more and more now, that when you're in the yellow zone, when the threat is not direct, that's when you do conversions to pack instead of putting a tourniquet high and tight. So those are just my comments, but I wanted to also ask one question, and that is about putting a tourniquet on loosely. That's always been not advised. A tourniquet high and tight or tight any place is advised because we want to prevent or want to not cause venous congestion. The concern is that if you put a tourniquet on loosely, one, if the bleeding's underneath your clothes, you can't really maybe tell how well the bleeding has actually been stopped. But the other concern is that you may occlude the venous flow, but you still have arterial flow, even if it may not be going to the end of the limb, but it's going into the limb a bit, but the flow cannot exit the limb because you've occluded the venous, and you have a much higher chance now of having congestion of the limb, compartment syndrome, and probably tourniquet syndrome. We actually had, I've seen 2 cases of this, one in an ER where, in the US, where a young man was brought in after being shot in his right thigh, and he wasn't an obese man or anything, just a young, probably 20-some-year-old Caucasian male. In the wrong place in the wrong time, so he was shot. And his limb, he was talking, so no other injuries. He was completely lucid, no other injuries at all. And his leg was completely white as his skin. So, and the way the EMS brought him in, I'm not sure what the tourniquet time up to then was, but his limb was completely white, which is what you would expect when you have good, full occlusion of both the arterial and venous flow. I was there as an observer, so that was the involvement of my activity there. We were monitoring the ER just to see how the processes worked. The residents came in and the attendings and let down the tourniquet to see if the bleeding was stopped and a tourniquet could be taken off, which is something that they had done in the case before. And in the case before in the arm, the bleeding had stopped, so they took off the tourniquet. Well, in this case, the thigh blew up into a watermelon immediately. So they quickly tried to put the tourniquet back down again, but within the next 5 to 10 minutes, the leg went from a very obvious white to pink to rubber to totally black as coal. And that man probably lost his leg, if not his life. Another case was during a class that we held a few weeks ago. One of our students, we have everyone practice on each other, as many things do, but we do a scenario. And in this scenario, this person, a young woman, had a tourniquet placed on her thigh. And within just a few minutes, within 2-3 minutes, her legs started to turn blue. And of course, we immediately removed her tourniquet, but the concern there was that it was a venous tourniquet. She may have had her thigh, her leg tensed when the tourniquet was put on. And that is something that we see in a lot of training videos, that people are taught to put the tourniquets while their leg is tense. And then if they relax their leg, the tourniquet will get loose. We saw that recently here. I teach tech and ATLS here. We were going through things with one of our instructors, and he was sitting in a chair, placed a tourniquet very nicely on his leg, but had his leg foot standing like on the ground. And I intentionally let him do that and then asked him, and no fingers could go under the tourniquet. Let him then relax his leg, push it out a little bit, and he could put his whole hand underneath this tourniquet. So I greatly support that we need to do better training. I don't think that the programs we have are wrong or inappropriate, but I do think that the way maybe that they're being trained and applied could really use a bit more attention to the quality of the training that's put forth. So my question is to the Colonel, as to why is the suggestion of placing a tourniquet loosely or placing it only until bleeding stops, because that's not, I'd just like to know the data behind that or what the thoughts about that.
So thank you, Dr. Roxolana, who's online. Dr. Roxolana is head of the World Federation of Ukrainian Medical Associations, WFUMA. She's one of the co-sponsors for this event. So thank you for your question and for your insights. And just before the Colonel's answers, I just want to, anyone else who is online on our Zoom, if you would also like to weigh in, please raise your hand on our Zoom, and we will get to you after the Colonel's response. Colonel Prohorenko?
Thank you, Roxolana. Indeed, we've been cooperating with Dr. Roxolana and FUMA for a very long time. In 2014, we started TCCC trainings in Lviv. And the instructors were trained for Ukraine, instructors for Ukraine, and to the best of my knowledge, this training continues, and the work that has been done is very, very important. Regarding applying tourniquets, there are various situations. In combat environment, when a person is stressed, applying tourniquet, it's very hard to note whether a limb is tense or loose. And in those situations, the indicator for effectiveness of tourniquet application is whether bleeding stops or not. There are people built differently, and some can tighten the tourniquet to the point where not just bleeding stops, but blood supply stops, and this causes intense pain. In other situations, the tourniquet could be applied not too tight, which could be a good thing for us. For example, in the cases when the assessment of the bleeding was exaggerated and not tight enough, application of the tourniquet can help stop the bleeding, but also keeps the blood supply, saving the limb. Regarding tense or loose limbs, indeed, if there's much muscle and the muscle is tense, after the patient receives painkillers and the initial shock fades away and the person relaxes, indeed, you would need to check the tourniquet, because the bleeding might start again. And of course, every case is different, and when you receive a patient with a tourniquet applied, these patients are critical, of course, and they require our attention first and foremost, and they require decisions to be made. Thank you very much. I will be very happy to talk to you later. We are developing a plan, and we will be very
Prevent venous tourniquets from being in place, because what's called a venous tourniquet, when you occlude the venous flow, but you don't of the arterial flow. Дуже дякую вам. Слава Україні.
Thank you, Dr. Harvey. Mike or Dr. Hudson, did you want to weigh
Well,
in?
yeah, I really appreciate the comments and the way the training has been adjusted for the trying to avoid the tourniquet syndrome and effectively teaching the tourniquet conversion. Can you tell us about what the feedback is for those that you've successfully trained and have sent out to the field? And are these lessons that are learned and embedded, or because they're under the control of senior sergeants and officers who've also been, know the old way and may not know the new way? How well does this training stick?
And on that too, the colonel yesterday spoke about a decrease of 18% over the last year of the cases, and to Hudson's question, what's changed that's helped for that 18% decrease in the tourniquet syndrome?
That's a question for me, right? The thing is that the number of injuries did not go down, and we still have a lot of amputations. But the causes necessitating amputations are less connected to the tourniquet syndrome now, which means that this issue is paid more attention to. So any patient that ends up at a mobile hospital or other hospitals, we make sure to communicate information to their unit, to their commanders about these problems with tourniquet syndromes. And the medics and the heads of medical units on the grassroots level are taking measures and sharing this information with the soldiers. This is what Andriy was talking about. And what Dr. Hudson Berrey was also talking about, that the soldiers need to know about the ramifications that the actions of their combat buddies might have in terms of applying tourniquets. So this is happening. Another thing, we have a tourniquet conversion program introduced. It's being implemented, and the combat medics are being informed about that. And I believe this is the reason for the decrease in the number of tourniquet syndrome cases. However, we cannot have 0 cases of tourniquet syndrome as of now. Unfortunately, it's still happening.
Thank you, Dr. Prohorenko. So on time-wise, we're doing pretty well. So we do have another member of our online audience. I'll let you, I'm not able to actually see the name, so could you please introduce yourself and just give us a little background, and we welcome your thoughts.
I think that's myself again.
Oh, sorry.
What I wanted to mention.
Sorry, Russell.
What I wanted to mention is that we're also looking at deploying a improved app that may help to emphasize the preferred way of applying a tourniquet, the 10 to 15 minute checks of a tourniquet once placed, and also the placement in a red, yellow, and green zones, and to emphasize that what you do in the red zone is not what you do in the yellow zone. So I don't know if that would help. So an app that one could have on their phone, or people can have on their phone. And many people already, the app is out, so just improving it.
Thank you, Dr. Roxana. Hudson, do you have something?
Yeah,
Because
I was in communication with somebody who has worked with the Azov Regiment or Brigade, and they had set up use of phones so that before tourniquet is applied, they had to, was it uncontrolled bleeding? Was it a traumatic amputation? Was it a mangled limb? Something that pressure couldn't stop. And so before, and I suspect this is probably not in the red zone, but in the yellow zone, where you can take the time, you're not under direct fire. And they said that really cut down on the number of inappropriately applied tourniquets to their soldiers who sustained wounds. But that was command driven as well. So I think, part of this is education at the soldier level. The other part of this is education at the command level, and that has to be pushed down to the units and has to be made an important point in taking care, because the commander is ultimately responsible for everything that happens. And this, just needs to be continually to be emphasized for both the command, the command side and also on the medic side.
thank you, Hudson. And we have another audience member, Dr. Chandra Hassan from Med Global. You had a question or some?
Yeah, it's a wonderful panel. Thank you, everyone. I have a comment and a question. When I was training as a resident, I had an opportunity to do trauma training at the University of Pennsylvania under Dr. Swab. At the time, military surgeons are coming back from Afghanistan and Iraq, and they're bringing their experience. So even the surgery of damage control surgery concept really had a lot of resistance in the beginning. People tried to do a complete surgery and not a damage control operation. But they did change it. We used to play that CD-ROM, which lasts 60 minutes. And by then we stop, when the music stops, you stop the surgery. So the point being, when they developed these guidelines based on their experience, it worked. Like Dr. Hudson Berrey mentioned, when NATO countries go to war, either in Iraq or Afghanistan, in their field they have field hospitals where you can get the injured soldier within an hour, whereas you are trying to follow a NATO guidelines without the NATO infrastructure in the field. So that is the big disconnect. How is that going to work? So from yesterday's surgeons, we see almost we are coming up to third year of this war. Ukrainian civilian general surgeons have as good as war explosion injury and other war injury management like NATO or United States military surgeons. So outside of NATO countries, most of the countries have limited resources on the field. So with this experience you have gained, both civilian surgeons and military Ukrainian surgeons, isn't it time you develop more guidelines to suit your reality that could help rest of the world in general? Just like TC3, which was developed by America, you could develop, which could help limited resources country. That's my question. Thank you.
Yeah, thank you, Chandra, for that comment. And as you know, with Med Global, David Knott Foundation, we teach the damage control laparotomy concept. It's a big deal. But it also carries those same principles to the extremities. So it's very different when you're shot by an AK-47 or AR-15 or some other high-powered military rifle versus what you see kind of on the streets of America, like a 9 or 45 millimeter. Unfortunately, we're seeing more and more of those AK-47 and AR-15 type injuries. But, this brings up two important issues. One is proper debridement. The best antibiotic is proper debridement of a wound. limited use of antibiotics to only what is absolutely necessary, and a staged second look on these extremity injuries, which will also help to minimize the amount of tissue that's lost or ended up being sacrificed. It's a whole different concept than just the tourniquets that we're talking about now, but in principle, it's the same issue. Thank you.
Anybody else from the audience or our online participants? So we're running a little ahead on time, but maybe we should wrap up. Oh, you do have someone online? Okay, Roxalana, Dr. Roxalana, you please.
Hi. Yes, I wanted to comment to Dr. Chandra's comment, if I can. I really appreciated the comment. And the difference, again, of the timing for the US and maybe NATO partners of having an hour to a physician for evacuation, essentially, that's to a green zone. And what we really want to emphasize, and what the NATO training and the TCCC, which NATO uses, which the US government, US military develops, it's that yellow zone where you can do conversions, that yellow zone that you look for additional bleeding and direct pressure packing can really work, and that really can be much sooner. And so if the training is pushed down to all levels, because all levels have the same skills, it's just a matter of the critical thinking being applied differently so that they convert, right? Because at all levels, TCCC, all service members, everyone is taught to put on a tourniquet, to pack a wound, to put on a compression dressing. And it's those three skills that are the same skills that are used in conversion, whether you put on a lower deliberate tourniquet on a wound that's an amputation, as long as the patient's not in shock, right? Or if you have a limb that's still in place, and you can pack and wrap and then loosen the other tourniquet. So all those skills everyone has. It's just a matter of changing the critical thinking that's there. And we are experienced now with training a good group, a large group of journalists, actually, just a few weeks ago on these same skills. And so these are people without a medical background. They honestly were able to perform and go through the critical thinking well. And so I do believe that if we apply this to everyone, and I think that the prompting that was done by Azov is very, very smart, because whenever anyone's under such a duress, your thinking can be affected. But again, then applying the skills that we have just more thoroughly, I think can really potentially help this problem. But thank you so much for your question. It's really good.
Dr. Berrey?
What is the Ukrainian military instructions now coming down from the military headquarters or from the military command channels regarding, the treatment of these wounds? And as was, I think, Dr. Chandra mentioned, and I've thought about this, because we need appropriate guidelines now, because we will not have the rapid air evacuation of our patients in the future. If this conflict then extends into Western Europe, we will have the same issues with that. So what does the Ukrainian military, the medical arm, and the combat arms combat arms hierarchy, are they addressing? How are they coming up with new guidelines for their training?
With regards to the training, as I said, now we increase the time to train combat medics in combat units. If we talk about the individual training of the soldiers, we must know that currently we need a lot of teams of trainers. Why? After the training, soldiers end up at the front line, and there are losses, and the trained people, unfortunately, they are out of combat for some time. They need replacement, plus there's demobilization, and new people are recruited who had no previous experience neither in the army nor in the medicine. And talking about the medical arm and the guidelines for care, starting from the battlefield and at stabilization points, and then in medical units, in mobile hospitals, the evacuation to the fourth level, there is now the standardization of care. We understand that when there is mass influx of wounded people, we must consider the resource available, and there should be some standardized assessment of the resource of doctors. What do I mean? Now, in the military, there are the graduates or the experienced specialists with huge experience in different medical areas. There are professors, associate professors. They also are serving in the military. So, talking about damage control, we are saying that, well, the recent graduates, they must do the maximum from what they can do. Stop the wound, stop the blood, decontaminate, save life. And those who are overexperienced, they should stop timely. They should not use all the skills. They should not do the reconstructive surgery at this first stage or something. So a lot of attention is given to that, and we work with this, and the training which is conducted now with the medical staff, with the doctors, with the nurses, is standardized. And the courses, training courses organized by our Western colleagues, I can speak from experience. I took a course, the Monster Bridge course and the Asset course, which is implemented in TS, and David Knott's course, and I attended the Mid-Global training course in our hospital. They all are aimed at the same goal, to make the situation where every patient is saved with least effort. That's one thing. And secondly, that the disability as the outcome is minimized. And we understand that a lot depends not only on the medical staff, but also on the resource available, on what is available for them immediately. If we talk about mobile hospitals, I don't think any NATO country has a CT scanner or a dialysis machine at that level. They're just not part of the kit. But life shows that, unfortunately, we must have it. And, of course, our colleagues from NATO countries, they see the issues Ukraine encounters, and whether you want it or not, they try to apply it into the experience of their countries, and they understand that, yeah, air dominance might not be available, and then the whole chain of evacuation is much longer, and extends the time for evacuation. And the most important thing is the lack of medical staff. We must remember that, because the medical service, well, has a limited number of medics, and unfortunately we have losses. So there are many issues, and the command of medical forces applies maximum effort to deal with all these issues step by step or jointly. And I can say that Colonel Humenyuk, the chief surgeon of the armed forces, he does a lot of work in all the directions. I don't know what is the source of his stamina, but he manages all that, and on all the issues of the field surgery, starting with the Tourniquet convention and down to the use of laparoscopy for different types of trauma. He deals with all of that. He has the team working on that. So there are many issues, but yeah, they must be solved.
Thank you so much, Colonel. So I think at this point we'll start to move just towards to wrapping up. So we'll have a little time to take a break before our next session. If we could, just maybe let's think to summarize and to think for Michael and HUD in particular, how we as outsiders, as guests, with our background and experience from the West, what can we do better, or both to help Ukraine, but what can we do to help our own healthcare providers, both in NATO and in the healthcare structures back in the U.S., do a better job to understand these issues and perhaps facilitate better collaboration with Ukraine on this, because I think we all recognize how big of an issue this will ultimately be for NATO.
Yeah, so I think we need to listen to the Ukrainians to understand what the issues are that they're facing, and figure out a way that we can best help and maximize what we're doing. I think the other issue that we've talked about in the past is having our NGOs that are working in parallel work together, collaborating better, and building bridges, and presenting unified training, and making sure that we're extending that training to as broad an audience as we possibly can. And it certainly helps when we bring our knowledge and what our experience has been in America to here, and that we collaborate with our partners here in Ukraine to really maximize the appropriate and safe care for the wounded soldiers and civilians, for that matter, here in Ukraine.
Hudson, do you have any final thoughts on that?
I think in doing this, we have to understand what Ukraine's wants and needs are, and then we can supply our experiences and knowledge to their help. But I think understanding their needs, our solution that we have may not be their solution, but their solution is the one that it's important right now. And that's what we need to assist them with. We're not here to do it our way. We're here to help them do it their way, and with the best experience and resources. Always in a war, the medics are not the first priorities. It's hard for us to understand that. But in war, the priorities are to the battlefield and to success on the battlefield. And then we have to work with the resources that command gives us, and it's a fight for that. So we need to help understand what the limitations of the resources are and do what we can to help Ukraine get the resources. And so that they understand what the resources they need and where they need them, and it's our job to try to help them with that.
Thank you, Hudson. So, I'll let Dr. Prohorenko have the final words, but just to sort of summarize what but they'll be the best words. Sorry. So, just to summarize, just here, having listened to our talks yesterday and today, it's one of the main things that would be key would be prevention, and prevention requires prevention of tourniquet syndrome, and that's going to require, to some extent, guideline modification. So some of the traditional current NATO TCC guidelines, high and tight, perhaps need to be modified to as low as possible placements, to early tourniquet conversion or release and made to pressure dressing, and only apply enough pressure to stop the bleed. So that needs to be integrated into the education and training, but it's going to require acceptance across both the civilian structures, but also the military command structures, and that's going to need to filter down to where these wounds are occurring, which is near the front lines. And then from that, what will be needed is better treatment paradigms or improved treatment paradigms. And it sounds like that's already happening. We heard exhaustively from the great lecture that Dr. Dmitro Berrey gave yesterday about all of the process they are doing to standardize, and a lot of that requires using the best techniques surgically, medically, that are available, using the best technology and tools. They discussed about the use of rapid blood testing to make rapid evaluations. Hudson, you made mention of technology use, where consultations could be used even for the medics or frontline physicians at the stabilization points that may not have the most information, where they can communicate with more experienced physicians in the rear. And as Dr. Prohorenko just told us, make the best use of the both material and human resources that are available in this setting. And Hudson, you made a great discussion yesterday about how they would place units one feature behind the battlefront, then basically those units would go into to use all of their resources that they had on hand and would work to exhaustion and then rotate. And I think there was a lot of discussion about having those forward, the fast, the rapid medical units that are dealing with, be able to rotate out, so they're able to maintain not only the standards of care but also the quality of the care that they're providing. And Dr. Berrey and Dr. Sopkos talked about that, and all of that maintains motivation, which is also a key, because this war has been going on for nearly 3 years and everyone's exhausted. And how do they continue to see optimal results when the volume and complexity continues? So I'll just, any last thoughts from our guest, Dr. Prohorenko, about what we're here as guests, we're here as colleagues, and we're here to help because we care about Ukraine, and because we know that what happens here affects all of us in all of the free world. But you're the ones fighting the fight, you're the ones that are having to contend with these issues, but are there ways that we can do a better job coming from our medical NGOs and from other countries to better help Ukraine? So if you could just perhaps end on that note for us.
First of all, I would like to say thank you for the support and help that you are providing now in this difficult fight. And the war goes on for 10 years. The 3 years of the full-scale invasion, they have heightened this, the degree of it several times. And in any war, in any conflict, we need soldiers, weapons, and ammo. And that all, unfortunately, is expendable. So so we run out of all of that. But the soldiers must be trained, and we've seen how in 3 years combat tactics have changed, how the weapons are changing. There are completely different weapons used to kill these poor people, and we need to do something in response to all that. You are in contact with the doctors and nurses in our medical forces, and you see that mostly they are young people, and they have graduated from medical universities, and they have had like 2, 3, well, sometimes more, sometimes less years. But in their regular life, these people, as soon as they finish their residency, they, well, should have been acquiring the experience you've been having in many years. And well, unfortunately, in peaceful life, usually there is not so much trauma when you have to treat, but we have this situation, and these young surgeons are there in operating theaters. They provide care to different patients with different types of wounds, and this requires skills and knowledge and so on.
And Dmytro Bishlei is a vivid example of how the implementation and interaction between civilians and the military does work. Indeed, the medics, the doctors of the armed forces, the evacuation staff, the capabilities of the armed forces do not allow to help everyone that needs help, unfortunately. So cooperation with the Ministry of Health and implementing treatment controls, treatment standards, in particular damage control standards, are being implemented throughout all the levels. In terms of the chain of evacuation, the second stage could have more control, and the third stage with even more control could be performed at various medical institutions. And at all stages, a person needs to be aware about what is being done to them. So what Mike said, all the training courses are very important indeed. They are after one overarching purpose. And if there is cooperation between the donor organization, this could make this cooperation much easier and smoother because more servicemen could be trained. I understand that this is costly, all of these training courses. However, it is important and it has to be done. And And I'd like to emphasize that the experience that we have will be systematized after the conflict is over. And in open sources, there will be numbers, the percentages, and we will be able to provide information about things we encountered and the solutions that we used. And those young people that are performing surgeries on our wounded, they will be able to be the instructors. And I am convinced that this experience needs to be documented and preserved. And we are very open for communication, and we're extremely grateful for the help we've been receiving. It's invaluable. So once again, on a personal behalf, on behalf of my colleagues, I would like to express our gratitude. And the meetings like this one organized by our colleagues are very important. Thank you, and I'm looking forward to future cooperation.
Thank you so much. Дуже дякую. So just to, we'll take a break now. The next session that will be coming up at 11:30, we have lined up for that retired U.S. Colonel Andrew Kapp will give a brief presentation about blood transfusions, and which is another very important topic. Some of the members of this panel will be helping to discuss some of the issues there. So after our brief break, please come back for presentation and discussion at 11:30. And we've brought this up before. You've all been receiving the emails from August Mission about the registration. We sent out an email about a WhatsApp community that you will join. Some of these open source materials that we've talked about, we're going to be distributing them there, letting attendees have access to that, and hopefully continuing beyond this meeting today, our ongoing discussion, our ongoing relationships and friendships we've built here, so that we can continue these dialogues even after here today. We'd love to have Dr. Dmytro Beshley, Roman Sobko, and yourself and others come and speak to our colleagues. We have a lot, we have already learned such incredible amounts from all of you. And again, this is a partnership, a sharing, and we learn from each other. So again, thank you all, and thank everybody for participating today. We'll take a break till 11:30.